dealing with innominate artery issues. Also, sometimes the innominate artery is quite tortuous. It makes it difficult to land and to seal. And with regards to the second question, how we deal with endoleaks and how frequent are they? So type 1A endoleaks frequently occur in about 20% initially at the final angiography, which is a reason. The reason is that the endograft does not oppose very well to the graft replaced ascending aorta. We usually accept that until a 3-month follow-up. If a 1A endoleak still is present, we would go in and use coiling techniques in order to occlude those endoleaks. And so far in our patients, we've been able to occlude type 1A endoleaks.
Okay, nice. Second question, we here in our center, usually we started off with the deployment of the device using the IVC balloon fluid, but other centers use atrial fibrillation or bradycardia, but some alone not using the IVC. In this publication, you wrote something about the STs, atrial fibrillation sometimes. Do you believe that IVC ballooning has an advantage in this issue?
Well, that's a very good question, and you're completely right that the standard technique for cardiac output reduction in the world today is pacing. And it's only a few centers who use IVC occlusion techniques. I find this occlusion technique easier to practice as it is more a mechanical kind of protection for my deployment, and I've never been really good at ECG readings, and I feel as a surgeon it's not a technique that I feel I fully control, while IVC occlusion is something I can understand easily. And the second advantage of this technique is that it gives you more time than pacing. Pacing, you have maximum 1 minute. With IVC occlusion, you have a little bit more. So that is something I would recommend to everybody to try, because it's quite easy and safe technique.
Okay, thank you for the clarification of this point. Next point that I always thinking about it, because up till now I seem to really want study, and there is nothing. I think up to my knowledge there is nothing in literature about the durability of breathing extent for carotid and innominate. And do you know if there is any sort of data about that? And if not, what's your opinion for your practice?
There's no, you're completely right, there's no data available about that, and our preferred technique is we try to copy what we do in the thoracoabdominal aorta, and that is use of self-expanding bridging stents or branch devices in which we have a distance to bridge from the graft to the vessel wall, and for fenestrated repair we do use covered balloon expandable stents like the Atlanta atrium, which is our preferred bridging stent. But there's only single center experience on this, so no good evidence so far.
So we can study.
Yes, that may be a project for you.
Yeah, I will. I see sometimes some cases, complicated cases, where the device might rotate or difficult cannulation. Mostly difficult cannulation happen frequently. What is the nightmares in this, and how you can overcome?
In arch endograft, the most important thing is always to have a plan B, what to do if your cannulation is not easy and fast. And in the arch, it's really important that you have perfusion of the cerebral vessels. And so the bailouts that you have is you need to get a situation where you have perfusion of the branch arch vessels. So how we achieve that in fenestrated endografting, we don't open the graft fully, we only open it partially. So if we don't have a good acquisition, we have enough time. And in branched endografting, there's a trick, which is that we always keep a catheter between the graft and the vessel wall, and if we push a stiff wire in there, and we push the graft away from the cerebral vessels, and we get perfusion, and by doing that you have all the time in order to catheterize. So we have had situations where we needed an hour to catheterize the vessel, and the patient went away without any brain damage. So you need time sometimes, and make sure that you have perfusion to the arch vessels.
Okay. If I want to know about your practice with transapical access, sometimes in classical cases it's difficult to bring the device down up from the femur. So we have also plan B for access. We used, I think, in 60 cases or more, transapical access. What is complication and what is the indication?
Transapical access is a great route to the ascending aorta. So especially when it comes to short tubular stent grafting of the ascending, I would think that transapical access is better than transfemoral access because we have a straight and easy and large bone route to place the stent grafts. The risks obviously are when if we have very sick and old patients, then myocardium is very bad. And if the cardiac surgeon, who always helps us with that, cannot control bleeding from the apex, then that is a significant issue. But I would hope that transapical access gets a more regular access in our practice, as a lot of things are easier with transapical compared to transfemoral.
Okay, thank you. Last question. There is any rule for these devices because it needs to be ordered before and maybe not available at our center. Do you face any urgent ruptured bleeding aortic ulcer or ruptured aneurysm, and do you use these devices suppose ordered for another patient? What do you believe the role of these devices in emergency situation like rupture?
That is a very good question as well. A significant proportion of patients with arch disease come in as urgent cases, as you say, ruptured or dissected. And if you don't have these devices on the shelf, there's no option of endovascular treatment. So, as you said, we have used devices that were not used for other patients, and it worked well, which proves that this device is a potential off-the-shelf device. And I hope that we will have that as a regular off-the-shelf CE mark device in a few years. But to give you a realistic time experience, the expectation, I think this will be 5 years until we have a CE mark of this study, because we first need clinical approval studies until this is really available. Okay, thank you for this great experience and the clarification of each one for my question. Really, today I learned from you. Many thanks. Thank you. Thank you. Let us start with the second topic. Second topic is endoleak. So let us start. Okay, so the second topic is a more day-to-day topic than the aortic arch treatment, as I'm sure you're also all aware of the presence of type 2 endoleaks and may see these patients in your daily practice. And just go through some of the basics. Endoleak detection after EVAR is quite different between 10 and 50%. I would think it's even more, because it depends very much on the imaging quality, whether you see a type 2 endoleak or not. The prevalence decreases during follow-up because the type 2 endoleaks disappear. Usually they're benign and only a few patients require intervention. If we look into the guidelines, there's clear indication to treat type 2 endoleaks as soon as we have aneurysm expansion. So if an endoleak leads to pressurization of the aneurysm sac, which leads to expansion, then we should treat it. Even though the evidence is not very strong so far. The same recommendation comes from the European guidelines, which indicates a sac increase of 10 millimeter, which I think is quite too much. I think if you have 5 millimeter, you should already treat a patient that have endoleaks, even though it's type 2. There are a number of morphological factors that are well known that they contribute to the occurrence of endoleaks, which is the number and the size of aortic side branches, and also the degree of thrombosis within the aneurysm sac. So the less thrombosis you have in the sac, the more likely it is that you get a type 2 endoleak. There is a large number of studies that look at that, and you see that here is even a summary of 35,000 patients, which gives probably a realistic number of 20% type 2 endoleaks at a median follow-up of a few weeks, and they list the same kind of risk factors for type 2 endoleaks. Theoretically, there is an option to prevent type 2 endoleak by preemptive embolization of branch vessels as well as the aneurysm sac, and this has been proposed both for the IMA as well as for lumbar arteries. And another option is to do this embolization during the main procedure itself, and most recent developments with aneurysm sac sealing techniques, the NELIX device, have come up and showed that type 2 endoleaks can be abolished with this technology. This is a study that looked specifically at the option of preemptively embolizing the inferior mesenteric artery with plugs, as you see here. And I can understand, I would support groups that do this, especially in large mesenteric arteries, even though I think there's still evidence missing that this leads to less reintervention. There are more studies who do the same thing. You see that also this group uses this Amplatzer plug 4, and the advantage of the Amplatzer plug 4 for the technique of IMA embolization is that it can be delivered through a 35 catheter size, and you see that there's quite a significant technical and clinical success rate. From the group where I learned in Malmö, we have looked at preemptive embolization of the IMA, and in a group of 70 patients this has been done, and what we could see here is that routine preoperative embolization of the IMA was not associated with a decreased risk of reintervention for type 2 endoleak. So it is very weak data that is available, and some groups do this and some others don't, so there's no strong recommendation. This is two of the studies that look at the use of NELIX, which uses a large bag in the aneurysm sac that is filled with polymer and thereby prevents type 2 endoleaks. And it has been successful for prevention of type 2 endoleaks, but it has also been associated and recently recognized that there's an increased risk of migration and type 1A endoleaks. So at the current moment, this technology cannot be encouraged, but it's delivered freely through a catheter or a sheath that is left after the placement of a standard EVA device. And we will certainly hear more about this in the future, how successful this is to prevent type 2 endoleak. This is another group in Italy that looks at preemptive embolization of the sac. So in contrast to IMA embolization, there are also groups that advocate that you just put cords into the aneurysm sac, which is of course technically more easy. And these groups claim, as you see here, that this leads to reduced occurrence of type 2 endoleaks, which may require further intervention. And this is another group from Paris, Dominique Fabre, who looked at the same technique of preemptive intraoperative embolization, showing that good results, and only using it in a subset of patients that had a large number of lumbar arteries and patent inferior mesenteric artery. And this is just another study, and we go over this in the sake of time. So that then we come to the treatment options for type 2 endoleak, and these options include transarterial embolization, which is the classical way, translumbar, transcable, paraendograft, transendograft, transabdominal, laparoscopic ligation, and you can see that this is a large variety, And I don't think that every center needs to be able to do all these techniques, but maybe 2 or 3 are necessary to be practiced in every big center. And I will go into some of these. As you see here, there's also always the option of open treatment of type 2 endoleaks by opening the aneurysm sac, leaving the stent graft in place and sewing over the ostia. Yes. The transarterial techniques that you see here can be divided actually into 2 big groups. One is the embolization through the SMA and the gliolam arcade going into the IMA, and the other technique is the hypogastric lumbar pathway where microcatheter is introduced through the first hypogastric branch into the lumbar arteries going into the aneurysm sac, as you see here. The issue with this technique is that it's usually time-consuming, requires a lot of interventional skills, and also shows a high recurrence rate, is usually a larger number of side branches contribute to the endoleak. Translumbar embolization has been popularized, and especially with the use of CT fusion, this can be done relatively easy. So as you see here, a needle is introduced into the aneurysm sac, and then usually a sac embolization is done using glue, as in this case, or using coils and other occluding materials. The advantages are that there's a high success rate. It usually doesn't take a lot of time, but the disadvantage is that it's usually a non-selective technique. There have been studies comparing both techniques and showing that the effectivity of the translumbar embolization is comparable to transarterial embolization. The technique that we use as our standard technique in Hamburg is the transcaval embolization. I will show you a few more slides on this technique. It is a relatively recent technique, and it's been introduced by Italian groups about 10 years ago. And as you can see on the images on the left-hand side, the vena cava is usually quite adjacent to the aneurysm sac, so there's usually quite some contact which allows puncture from the IVC into the aneurysm sac. In the beginning, this has been done from a transjugular approach, but most centers today do this from a transfemoral approach. The advantage is that we can stand at our usual right side of the patient and get a decent distance to the aneurysm sac, so that we can use also selective embolization. And this is another study from Italy looking at transcaval embolization of a number of 26 patients. And what this study showed was that the selective embolization, which was the majority, was more successful than the non-selective. So selective means when you have a catheter in the aneurysm sac in the nidus, you use a microcatheter to go into the small side branches and embolize the side branches, as you see here. This is called selective embolization, which is more effective than non-selective embolization in the aneurysm sac. Another technique is that power endograft. This is also something we do in Hamburg in cases that are not good for cable embolization. And power endograft embolization means you just press a catheter between the stent graft and the vessel wall, and thereby get into the aneurysm sac. And it seems, it may look difficult, but it actually is not, as in most cases you can find your way inside of the endograft. Another technique is to puncture the graft itself, and it may not be necessary to use laser, as in this publication you see that the group here uses a permeable sheath, which then allows introduction of a laser guide that then cuts a hole into the graft and thereby gets access to the aneurysm. The advantage of this that it's also relatively direct access, but you have to use a covered stents after that to occlude the hole that has been created. This is a very rarely reported technique, transabdominal embolization, where the needle is punctured directly through the abdominal wall, and it requires that the aneurysm, as in this described case is very close to the abdominal wall. This can also be done laparoscopically. I think you need really a lot of skills to be able to combine this fluoroscopic techniques with laparoscopic techniques, and you really need a large OR. And we hop over this, and just to come to the results of our preferred technique of transcaval embolization. What we do is we don't do this prophylactically because I think it's the percentage of patients that require embolization techniques is too low to treat everybody. We prefer transcaval embolization if possible, and if not, we do transarterial mainly. Open ligation only is used if necessary, but other techniques don't work, which has been the case in 2 patients in the last 9 years. We have treated also a limited number of patients with transcaval, as you see here. Probably we're up to 25 right now, but this is the number that will be in a publication very soon. We did not manage to go selective in all the patients. We use coils and glue for the technique. And you just see some images here. You see also that the procedural time needs a little bit more than an hour. We did not have any significant complications, and you can see that the patient that we have some significant follow-up showed no significant increase in sac diameter. I just want to share with you a short video showing this technique. This is the needle that we use. It's a transeptal needle that has an indicator for the direction of the needle. We like to use fusion, and this is the moment where the aneurysm sac is punctured with a transeptal needle. The needle is moved forward into the aneurysm sac. You need some good